the challenge. So one has to be conscious of this and take appropriate action. Rest of the surgery always remains the same. I think I'm done. Vardhaman, are we ready for the next talk? Then I'll just conclude over here. Otherwise, I can show one more video.
No, you can go ahead and show one more video.
Sure. Okay. So now this was a situation where again it was a pupil which was coming down. It was a smallish pupil, and while everything else looked good, we did a femto assisted thing. You can see on the MIOCT on the right side that the vault was very low and patient had gone on to develop a cataract. And we went with the similar steps as we normally do and brought this ICL out. So in a small pupil, it becomes a little challenging and you have to manipulate the haptics is what I wanted to show. That once the haptics are, two of the haptics are out, it becomes much easier. You can use a wide tip manipulator as well and bring the ICL into the anterior chamber, and then you can explant it. So small pupils can be a bit of a challenge. We've used phenocane in the past. I'm missing one video. If you allow me, I will just pull that video out. Otherwise, I wanted to finish here, but I'll just go into one short video in case.
Yeah. Sure. Please.
All right. So it's sitting right here. And I think I forgot to paste it into that. So sometimes this will happen. Can you see the video now?
Yes.
Okay. So sometimes you are going with a very clean case like this, and again, this is a non-centraflow ICL, which probably was done long back. And we decided to explant this ICL. I'll take you to the point which matters over here. We are first, of course, trying to get this ICL into the anterior chamber. And then I'm going to hold the ICL. And you can see I'm using a bimanual technique. With the left hand, I've engaged my dialer into that small hole. And now I'm trying to get this ICL out. And I will use the same technique as I've shown before in many of the videos. But you see, it just tears. Then it kind of worries me. So I go back thinking that why has it got kind of this thing on. And my incision I know is adequate. I've made it to 3.2 millimeters, which I would normally do. So I go back and I'm trying to position it so that I get a good grip on it. You can see that I'm using all the techniques in the book to ensure that I have a good grip with my ICL holding forceps. So I go to a thicker area and get a bigger grip on it. And now I've got hold of one of the ears of the ICL, or the foot plates as you might want to call it. And I'm depressing the posterior lip and hand over hand trying to negotiate it. And it's tearing again. You can see that there's a tear on the ICL. So why does this happen? That's what I wanted to share here. And I wanted to caution everyone because it doesn't happen to every ICL. This is, of course, a star ICL only. But you can see that it's become so friable. So basically what I would like to highlight here is that if the ICL has been in the eye for more than 10 to 15 years, the material starts degrading, and one has to be extra careful when bringing out ICL which have been sitting in the eye for very long. Otherwise, there's a chance that they will start kind of giving way and they tear. And as you pull them out, so an adequate incision, a good grip, and also be prepared that you have to do a hand over hand technique, and you can expect sometimes that ICL to kind of give way and tear, and then you might want to go back and bring it out. Of course, it eventually will come out, but this kind of makes the surgery a little more challenging. So I think I will stop sharing my screen after this, and I hope these were useful tips that I could share from experience.
Yeah, thank you so much, Dr. Gaurav. I think it was definitely a great, let's say, bouquet of the videos. We could see actually all the different difficulties that you have faced and how you have come successfully out of it. And as you have rightly said, now I think they have clocked now 3 million ICLs all over the world. And that does mean that actually, and we have all seen globally, ICLs are becoming very popular now. I think the numbers are increasing exponentially. And that does mean that there will be a lot of people who will come back with the post-ICL cataract situations in the future. And such, let's say, challenges will be faced by all of us in the future, and the great pearls and tips that you have given. Now, I would like to go to all the panelists. they will share one pearl about the post ICL cataracts with all our delegates, and also post any questions to Dr. Gaurav from that side. So first we will start with Dr. Himanshu Mehta, sir. Yeah.
Gaurav, as always, wonderful presentation. Quite exciting to see that. Yeah, we have had experience from more than 12 years plus of ICL patients, pretty good. But ever so often, you get a cataract and it's difficult. One of the things with femtosecond laser is that if the rexis is incomplete and you not put in a viscoelastic between the anterior lens capsule and the ICL, when you're pulling it out, it's a little more pull push kind of a scenario, and you may tear the anterior capsule, and it can go haywire. So I've been very careful. In fact, in some cases when I'm not sure when the volt is low, I have kind of done a manual rexis despite having a femto. That's one thing that I would say. And as Gaurav pointed out, it very because there is gas liberation between the ICL and the anterior capsule. When the femto starts, there is a lot of bubbles which are formed underneath the lens. So that's where, and if the rexis, God forbid, is not complete, we can be in a mess.
Absolutely.
And yes, there could be some fibrosis in the posterior chamber there, and it's difficult at times. All in all, we are going to see a lot more cases. Out of 3 million, 1 million. So overall, iatrogenic increase in cataract is definitely there, and we are going to see it very soon. The explosion is coming pretty soon. Earlier, we were very conservative. Gaurav, how many? Not many earlier, about 10, 15 years ago, not too many were being done. But now there is an exodus of people doing with IPCL and everything going on. So we're going to get an exodus of stuff. So that was one with respect to femto that I would be careful about. Otherwise, it's a routine cataract. Yes, as he said, the incision has to be bigger. So your sleeve could be bigger and fatter. You could, instead of using a small 2.2, you could use a 2.8 kind of with a 3.2 sleeve. That will make life a little more easier. That's all. Otherwise, the cataract is pretty easy to get over with. But remember, they all are high myopes, and that's why you've done an ICL. Quite often, most often than not, rather, it is either minus more than minus 10 plus. So the retina is weak, and that's where the challenge lies. So they could be getting into other kind of trouble. So you have to be careful monitoring that. And the patients think number gaya to retina bhi normal hai. That is not the case. So examining the retina regularly would be a
Also, these patients have high expectations because they have previously had a refractive surgery. They will want themselves to have post ICL also. Once you do the cataract, they'll expect you to have spectacle free vision, which becomes a challenge, especially if there is high astigmatism and your ICL power is very low. I mean, your IL power is very low. You may not get a toric lens. So I've sometimes actually done an FM to LRIs to neutralize the astigmatism, and the lens power was like 1 or 2 diopters, where you don't get a toric. So, but very valid points, Dr. Manchu.
And the bigger social cause, Vardhaman, that I would see, or you also might have seen, are these quite a few of these girls were unmarried when they had this high number. Right. And to tell after that marriage that you have to be socially nice, where you have to put it in a very formidable way to say that the cataract can happen in young patient. It's not an ICL. So it's a very dicey situation, which I can promise you. I mean, I've gone through it and I know how it is, because it can make or break a marriage. So you have to be careful with your words.
Yes. Yeah, absolutely. Thank you. Thank you, Dr. Himanshu, sir. We would like to now go to Dr. Vavikar, sir, for his comments, and if he has any questions for Dr. Gaurav.
Thank you. Gaurav has covered everything so well that there is hardly anything to talk. However, just expanding on Himanshu's point, that I would, for doing a LASIK or a flax cataract surgery, I would increase the delta and I'll increase the energy for capsulotomy so that I get a perfect rexis. And the nucleus is most of the times not very hard. So I would save energy there. So, using the energy for nucleotomy into this. The second point I would like to emphasize is that we don't see the patient walking in the hospital with a thick glasses, and therefore sometimes we misjudge the issues associated with myopic cataract. Even though cataract is not hard, you can get deep AC, and the angle of attack is not, it's very more acute. Even though the cataract is not hard, sometimes that can get into trouble. So we have to be very careful about that. The third point Gaurav already mentioned is that when doing femto, we have to adjust the lens, the reflection go from the lens, and the lens is perceived as the anterior capsule. Same thing can happen when we are doing immersion biometry. And therefore, we have to ensure that the spike is coming from the anterior surface of the lens, crystalline lens, rather than from ICL.
Very good point, Dr. Bhavikar, and that's why I call you as the master of guru of biometry.
Indeed, indeed. Yes. Dr. Ladi, sir, please.
Hi, Dr. Gaurav. It
I
was such a beautiful display of variety of surgeries and this kind of experience on this many of cases. I think only very few people have in the world. It was amazing. Many times a machine doesn't know what it is. Like suppose you are using a femto laser, then this what you rightly did was to put that cursor from the you can say ICL to anterior capsule, where you could come onto the anterior capsule. But in between, there were you can say bubbles from the either siliconoid or something other than that. So they don't know. The machine doesn't know what it is. So machine doesn't know what it is. So at particular point in that region, we can increase the energy because these cataracts are very soft. So they don't need any energy as
Zero.
far as the cutting of the lens is concerned. But it may pursue that air bubbles or silicon air bubbles or opacities as a hindrance for the surgery. So machine doesn't know what it is. So that particular region, when you reduce that level to the anterior capsule, at the same time, energy levels should have increased. Where there is one more, there is a cursor there where you can go increase that energy and come back so that at least that part gets removed. And when you come to the lens, you can keep the energy as low as possible because it's a high myopia. Another issue with this is that since these are high myopic patients, we should keep that posterior capsular, you can say the protection level, which you usually keep as a 500 or 600. We should keep as a 700 to 800 because division of this nucleus is not a big issue. So if you cross or you can say divide anterior one third of the nucleus is fair enough for this type of cataract. So there we can keep, you can increase the level of the posterior capsule margin and only increase the energy for the anterior capsule. So that's one point which is what we can take home from there. Whenever there is an inflammation which you see on a slit lamp before we take the patient into the OT, like this which happened in a third case where there's an inflammation, instead of using the tips of the forceps, we can use the shaft of the forceps because they get so fragile that you may get the coming out, that you
Oh, I think we lost him.
try
Yeah,
to pull
see,
somewhat.
some.
right.
But I think the point is very well taken, and both of you have said exactly the same thing. In fact, I don't even use nucleus. I mean,
Right.
softening. I mean, I don't use anything because most of them are so soft. I think the Rexis is what you really want, and increasing the energy is absolutely the correct point. So,
Yeah.
I think very valid points. Thank you.
So how, so last question to you, Dr. Gaurav, is that how would you, because as you know that when you have myopia and these patients who have pathological myopia are the ones where you are doing ICL, and the studies have also shown that as your myopia is increasing, their possibility of getting early cataract in their lifetime is also higher. Like for example, who has more than 6 diopters of myopia, their statistical chance of getting early cataract is about 4.5 times higher than a normative data. So how would you differentiate that this is the aftermath of ICL which has caused this cataract versus this is a cataract which is because of the myopia related issues? Yeah.
Well, very good question, Vardhaman. And I think that, what we noticed today, in fact, frankly, when I'm actually implanting the ICL and counseling patients about ICL, I usually tell them that, as a high myope, you are as it is going to be prone to cataract formation a little earlier than the rest of the population. So that thought is already put into their mind because when they come back to you maybe 10, 20 years later, they will already keep it in the back of their mind that, there is possibility of getting a cataract. That's one thing. But to answer your question, frankly, what I see now is that ever since we started doing center flow, I'm not really seeing a significant incidence of cataract which is induced by the ICL in general. Okay. If it does develop, I would put it, but we all understand there is going to be more endothelial loss. I mean, and compared to a normal eye, and there's going to be earlier cataract formation. Problem is, that we still haven't probably reached that stage where we'll start seeing that huge, volume of cataracts coming in with the central flow. We are
Right.
already seeing that with the patients who did not have the central flow, and I've removed quite a few of them who
Right.
went on, and they did obviously develop early cataract. But frankly, I'm following up now some patients who have warts as low as 100 microns, and they've been, I've warned them about the cataract. I've told them that we can do an ICL exchange. They've opted not to go for it. And
Uh,
in 5 or 6 years of follow up, we've not seen any formation of cataract progressing at all. So
right.
I don't know how to answer this question because we are still in that stage where we are not really seeing that higher incidence of cataract from the ICL, except when that one patient where we got very bad inflammation. So there,
Right.
of course, there is a clear evidence. Yeah.
Correct, correct. Yeah, great. So thank you. I think this was definitely a very, very important and pertinent topic and talk and wonderful overview of the situation, Dr. Gaurav. Thank you so much for your deliberations and all the discussion.
Thank you, Vardhaman, and I must congratulate you for doing such an amazing job. I'm following a lot of MOS webinars, including the one which was there 2 days back. So I must congratulate MOS team, the BUA team. You guys are really setting the benchmark for the nation, and please continue to do this work. I'm going to enjoy Dr. Sinjab's talk. I really look up to him for all that he does, and thank you for making me part of this webinar where he's also speaking. And so I'm with you all through, but now I'm going to enjoy it not as a speaker but as a audience. And thank you, Karishma, also for and Dr. Himanshu, everybody there for being here. Welcome, Dr. Sinjab, and I'm going to become quiet now. Thank you so much.
Thank you. Thank you so much, Dr. Gaurav. And from both the team of Maharashtra Ophthalmological Society and Bombay Ophthalmological Association, we are honored to have our international faculty, the star speaker, Professor Mazen Sinzab. So welcome, Professor, to our forum. So I would like to now introduce Professor Sinzab. I'm very sure that he doesn't need any introduction. But just to do the formality, Professor Sinjab is consultant of cornea, keratoconus, and cataract refractive surgery at Dr. Suleiman Al Habib Hospital at Dubai. He's the founder and the president of the Sinzab Academy, which has just clocked 10 years. And there have been world over numerous thousands or probably even more than 100,000 people who have watched so many videos that Professor does. And he has created so much of clarity about both cornea, cataract, keratoconus in this community world over. So we thank you on behalf of everybody for that, Professor. And he's the founder and general secretary of the International Keratoconus Society. And I have been very fortunate to work along with Professor Sinzab as part of the scientific and the educational committee. And I have seen the way he organizes things, and his academic and the scientific deliberations are always to learn from. He is also the president of Miyako Cataract and Refractive Surgery Society. He is board examiner for both Royal College of Surgeons in Edinburgh and Royal College of Ophthalmologists in London as well. So we are very, very lucky to have you, Professor Sinzab, with us. And we would like to thank you on behalf of both MOS and BOA. And we would like to now request Professor Sinzab to speak to us about biometry and IL selection after corneal refractive surgery.
Hello, everybody. Thank you very much, Vardhaman, for the very nice introduction. Actually, I am the one who should be proud to be amongst such a wonderful team and panelists, wonderful surgeons that I'm sure that I learned from you a lot. I'm very sorry for being late, and I'm sure I missed a lot of things. So sorry for that because of that traffic. So and now, of course, thank you very much for the kind invitation for both the BOA and MOS. And I hope to have more collaboration in the future. And let us start now. So I'm going to share my screen, my presentation. And I think it is clear, correct?
Yes.
Okay, so I've been invited to talk about the biometry and IOL selection after laser vision correction. I'll go through the importance of tomography, high-order aberrations, then biometry, and the astigmatic correction. Starting with the tomography, why we must do tomography for every patient coming for cataract surgery. Because we want to be sure that the patient, whether they had previous laser vision correction or not, because this will change the plan. If we miss this, we will end up with a surprise after the operation. Now, to show you the importance of this, we have to study two important maps, the tangential front map and the relative pachymetry map, because those two maps will give us a clue about any previous ablation done on the cornea. For example, this is post-myopic. We can see on the left side a flat central area because of the central ablation. And the relative pachymetry map on the right eye will show us the disciform pattern which goes with the central myopic ablation. The minus values means that some of the tissue in the cornea has been removed. So the minus means ablation. So it is central means post-myopic. And this is post-hyperopic. On the left side, you can see the central steep island and the peripheral donut shape of the ablated area. And the same on the relative pachymetry map. You can see that the minus is at the periphery in a donut shape, which means post-hyperopic treatment. And this is post-astigmatic. So you can see the ablation on one axis. So by this, you can do a proper biometry to choose the proper formula. If you miss this and you use the usual formulas, even though they are the fifth generation, they will generate wrong measurements, as we will see later. Now, it's important as well to study the wavefront of the cornea because this will reflect on the selection of the type of the lens, as we will see. Now, 90% of the aberrations in the cornea are because of the lower order aberration, defocus or astigmatic. And only 10% are higher order aberrations that can be spherical, coma, or trefoil. And from this, many other high order aberrations are derived. For example, secondary spherical, tertiary spherical, secondary coma, tertiary coma, and so on. Now, what is the spherical aberration? We all know the spherical aberration because the refraction is not equal, but it is symmetric. And there is positive spherical aberration and negative spherical aberration depending on the relative difference of power between the paraaxial area in the cornea and the peripheral area of the cornea. Of course, spherical aberrations are responsible for the halos, which differ according to the severity and the pupil size, as we see. What are the representatives of the corneal asphericity? We have the Q value, P value, E value, and eccentricity. However, the main one and the most popular is the Q value. Why I'm talking about the Q value? In order to understand the spherical aberration induced by the corneal asphericity. When Q value is minus 0.53, we call the shape of the cornea as parabola, and there will be no spherical aberration. If it is more positive, then there will be positive spherical aberration and vice versa. Now, on either side, we have toxic and non-toxic spherical aberration and the usual spherical aberration that we see in most of the corneas, which is between 0 and 0.35. The non-toxic between 0.36 and 0.6. Above that, it is a toxic one. The non-toxic means that it is unusual, but the brain can adapt on it. And this is the principle of induction of non-toxic spherical aberration in order to increase the depth of focus in the treatment of presbyopia. However, nothing free, because this will be on the account of contrast sensitivity and depth of focus. So the more the spherical aberration, the less or the more affected contrast sensitivity and the less quality of vision, and the more depth of focus, but to some extent. Because if we exceed to the toxic area, then even the depth of focus will be very much affected. Now, our human cornea is on the positive side, and it is compensated by the negative crystalline lens, but we are going to remove the crystalline lens in the cataract surgery. So it is all about now the human cornea. However, we induce spherical aberration when we do refractive surgery. So in myopia, we push the human cornea towards more positive, and in hyperopia, we push the cornea towards negative. How about the coma? We are surgeons responsible to induce some coma because of corneal irregularities after laser vision correction. For example, decentered ablation or irregular ablation or not taking care of centration of the laser profile by the application and so on, many reasons. As well, there is lenticular such as subluxation, zonulopathy, decentration of the IOL. The coma, people will see shadows and ghost images, and we come to the trefoil where it is like Mercedes-Benz. It is called trefoil according to the trifolium plant. Now, the trefoil, this is how people see there are starbursts, let's say. How to study the wavefront? We have to look at the Zernike analysis, wavefront of the cornea, not front, not back only, but wavefront of the cornea itself, and to the sixth order with the maximum diameter of 6 millimeter only, and we study the pyramid. Then we click only at the M3, which consists of vertical trefoil, vertical comma, horizontal trefoil, and the spherical aberration in the middle of the N4. Then we look at the RMS of these 5, because these are the main 5 that we have to consider when we study the wavefront of the cornea. Here is the RMS. And if you are using a Galilei, you can do the same thing. But if you are using MS39 or Cyrus, unfortunately, you cannot select. So you have to be sure that you are studying the 6 millimeter and the total, which means anterior and posterior together, because you have to put in mind that the posterior corneal surface is a friend, and it tries its best to compensate for the bad spherical, bad high order aberrations induced by the MS. That's why when we treat, we have to consider both surfaces. So it is not only the anterior only. And here, this is the display of the MS39 and Cyrus. So you can see the RMS of all 6 lines of the Zernike analysis. But on the table itself, you can study in the table, as we see here upright, you can study each one of them as Zernike coefficient. So you can see the comma alone, you can see the spherical aberration alone, and so on. All right. Normal range of high order aberrations at 6 millimeter. No cutoff values, actually. There is no evidence because it is affected by age, ocular surface, dry eye, accommodation, and it is affected by the population of the studies and measuring devices and study design itself. However, there is a general agreement that if you are using the Pentacam and Galilei, that the cutoff value is 0.35 and 0.5. Above 0.5, it is abnormal. Between 0.35 and 0.5, it is suspected zone, but be careful, this is in microns, not in diopters. And if you are using Cyrus or MS39, we can just push the bar a little bit up. So the cutoff values will be 0.5 and 0.7 because it considers all of the high order aberrations. We come now to the types of IOLs and the interpretation of that on selection of the IOLs. We all know that we have the old spheric, which induces positive spherical aberration. We have the aspheric, and there are 3 types based on the induction of spherical aberration. So there are some lenses aspheric with 0 spherical aberration, which are very important when we have a doubt that there might be decentration in order to avoid induction of more complicated high-order aberrations. And it is preferred as well in irregular corneas and in keratoconus. And the other two are the negative spherical aberration of minus 0.20 and the other one minus 0.27. And the premium, we know that the trifocal and the EDOF. According to that, I created a system based on the amount and type of corneal high-order aberrations and patients' demand, reading versus quality of vision. Because some patients will come and say, okay, we want to read or work on the computer, which means that they want depth of focus. Some patients say, no, we want very sharp vision, which means that no depth of focus or the minimum of depth of focus. So I created what's called the PSIS algorithm, the practical subjective IOL selection. And these are the pillars. Premium IOLs are precious, so they have to be selected very carefully. And the aim after laser vision correction, corneas, the aim is to convert the toxic spherical aberration into non-toxic spherical aberration to be tolerable and to maintain the depth, the non-toxic for if the patient is keen for depth of focus. So if the patient has already non-toxic, then we can maintain it in order to keep the depth of focus that they have. And if no, the patient wants a sharp vision, then we have to try our best to keep the spherical aberration as close to the plus 0.1 microns as possible for sharp distance vision. So we can divide this into three categories. The high-order aberrations are normal, or they are abnormal on the account of spherical aberration, but the others are okay, or abnormal on the account of all of them. So if it is, I'll give you some examples. If it is normal, RMS is good. So here, if the patient is asking for depth of focus, then we have to use the premium lenses. If the patient is keen to have very high quality of the image, sharp image, then either we can use the negative spherical aberration, because remember, the normal cornea has positive spherical aberration. So we have to compensate it by either negative spherical aberration or zero spherical aberration in order to maintain a target very close to the plus 0.1. Okay, and you can see pre-op, post-op, what type of lenses we can use in order to achieve this target. Now, if the high-order aberrations are abnormal on the account of coma, trefoil, whatever, if depth of focus is needed, then we can use EDOF or enhanced monofocal. Of course, enhanced monofocal is better because if the high-order aberration is very high, the EDOF will complicate the thing, unless it is, for example, positive EDOF and the spherical, the high-order aberrations are on the negative side, and vice versa. If the image quality is very important to the patient, so we must not complicate the matter, and we can use either the zero spherical aberration or the enhanced monofocal. Now, if it is abnormal but on the account of spherical aberration only, of course, the patient either previous myopic or hyperopic. So in this case, if it is prior myopic and it is toxic, so we have to convert it into non-toxic. How is that? By using the maximum, which is minus 0.27 type of lens, as you see. And I just wanted to show you some examples, because if we go through all items, then it will be a very long session. Okay, how about the biometry? Of course, we have to validate the biometry, not only because the patient had previous laser vision correction, but in every case, we have to validate. Why? Because each 1 millimeter error in the axial length there will be 2.5 diopters IOL error and 1.66 in refractive error as a spectacle, for example. Every 1 diopter K reading error will lead to 0.9 error in the IOL and about 0.6 to 0.8 refractive error in the plane of glasses. And 1 millimeter anterior chamber depth error measurement will lead to 1 diopter if the patient is myopic, 1.5 if the patient is emmetropic, and 2.5 diopters if the patient is hyperopic. So validation of the captures is very important. Of course, how to validate, it should be to compare the parameters between both eyes and select 3 of them for matching and so on. Now, the source of errors in biometry in post-laser vision correction corneas, the source is of 4 reasons: instrumental error, index of refraction error, formula error, and post-op corneal shape error. The instrumental error, if we depend on the SIM-K, the SIM-K is taken only at the margin of the central zone, not in the central zone itself. So at the margin, 3.2 millimeter. All right, this is a problem. How about the central one? Second one, index of refraction error. We know that all machines are calibrated based on the very well-known standard ratio posterior to anterior, 0.81, or anterior to posterior, which is 1.21. So what will happen if we change the shape of the cornea because of the ablation? So no longer this ratio is correct. So there will be either overestimation of the K readings if it is post-myopic, or there will be underestimation of the K readings if it is post-hyperopic treatment. Okay? And if we are depending on even the latest 5th generation of formulas, because they estimate the effective lens position based on many parameters, but K readings is one of the parameters. So there will be either overestimation or underestimation. This is an example. Therefore, there are special formulas that we have to follow. Error number 4 is the corneal shape instability, especially after RK. There will be fluctuation. So usually the cornea flattens and sometimes occasionally steepens. So this is very important. So which formula? Now, I just summarized all the latest studies regarding the best formula in each case, as you see. So if the eye is standard virgin eye, then any of the 5th generation. If it is virgin eye, but with axial myopia more than 25 millimeter axial length, so the best are Kane, Evo, or K6. If it is axial hypermetropia, the axial length at virgin, less than 22 millimeter, then the same 3 formulas are the best. Now here we come. If it is post-laser vision correction or keratoconus, the best is to use the Barrett True K and using what we are going to talk about, as you see here. So we go to the Barrett True K formula. All right, we fill in the information of the patient, and then we press calculate. Then the formula will open for us 2 options, either predicted posterior corneal astigmatism, PCA, or measured posterior corneal astigmatism, PCA. All right, either PCA or MPCA. Let's go, because it is more accurate, to the MPCA as we see here. So we click on it and then calculate again, and it will open another page for us in order to fill. Now here, if you see, we have to choose which machine we are taking the parameters from, Pentacam or IOL master, because this formula is just for Pentacam and IOL master. So we choose, for example, Pentacam. And of course, previously, we already put myopic LASIK, as you see. All right, here, myopic LASIK. This patient post-myopic LASIK. Maybe it is post-hyperopic. So we choose the post-hyperopic LASIK, as you see in the this display. So we go back to this one. So, okay, I'm taking the parameters from the Pentacam, and I entered the flat K of the posterior surface and the steep K of the posterior surface. Accordingly, this formula will calculate to you the real ratio posterior to anterior, all right? Instead of depending on the measured K readings, which will make either overestimation or underestimation. So in this case, the posterior cornea ratio, as you see here, it will be calculated after we input all the parameters. Then we press calculate. Accordingly, it will give us the calculation. And this is the best way. So the measured PCA. Now, try yourself to find a patient and to use this way and to use any other fifth generation, which is not specialized for post-laser vision correction. You will find sometimes, or in most of the times, a huge difference, maybe 2 diopters or even more. We come to the last point, which is astigmatic correction. Now, of course, there is astigmatism sometimes patients after laser vision correction, and sometimes the astigmatism is irregular. So which K readings we have to consider when we plan for astigmatic correction? For example, I want to go for the cataract surgery. I did my calculation properly, and the IOL was calculated in the way I mentioned, and I want to implant. But the incision site, maybe should I go for toric or not? Maybe should I go for something, AK or not? So we have to know how to study the astigmatism. So one way is to go for the SIM-K, as we know, or the total corneal refractive power at 4 millimeter, all right? And if you are using the MS39 or Cyrus, this one is in the Pentacam. It is called total corneal refractive power. The other one, in the MS39 or Cyrus, it is called refractive analysis. You go to the mean pupil power at 4 millimeter. All right? Or you can go to the equivalent K reading, all right, at 4.5 millimeters as recommended by Holiday. You find it in the Pentacam in Holiday report. All right? Or you can go to the optical devices, central zone astigmatism. So which one of them? Of course, we have to depend on the optical device if it is available. But if the optical device is not available in your clinic, for example, then we ask ourselves, is it regular cornea? Yes. Then we go to the total corneal refractive power. You consider that one in terms of the amount of astigmatism and the axis of astigmatism. But if the cornea is irregular, you have to go for the EKR from Holiday report, because it is a kind of prediction of the real and the most accurate one. So as a take-home message, tomography is a must for every patient going for refractive surgery, clear lens extraction, or cataract surgery. High-order aberrations must be studied properly and in depth in every patient before going to cataract surgery. For example, if a patient has 0.6 RMS, if we implant trifocal for this patient, it is a disaster. The patient will come and say, please remove this lens from my eye. Biometry, the best after laser vision correction is the Barrett True K with the MPCA. Astigmatic correction, the best is optical. Otherwise, you follow the last slide I mentioned. And thank you very much again for waiting for me and for inviting me.
Thank you very much, Professor. I think it was a eye-opening presentation. I think probably the best I've ever heard in my life about in this topic. Thank you. Thank you for making it so comprehensive in a relatively short time. And we have dwelt on so many aspects of this post-corneal refractive surgery, cataract, biometry issues, and you have gone to the nuances of every single aspect of it. So I would like to now probably keep it open for discussion and start discussion with our panelist, Dr. Himanshu Mehta, sir. So your like on this lecture, your comments about that and any questions you have or any pulse more that you would like to share. Yeah. You're mute, Dr. Mehta, sir. Yeah.
So I'm basically clean bold. I'm speechless. And a wonderful presentation, Dr. Sinjan. Makes life so much more easier. I might just take a couple of days to digest what you said. And that's a fact of the matter. But wonderful presentation. Sir, having all these machines that we have today for keratometry and your pentacam and your topography, tomography, and your IOL master, which K reading that you justify actually? Which is the one? Because, and the axis, which one do you? Because these two could be disassociated. What is your reliable criteria?
Thank you very much for the kind words. Very, very excellent question. So if we are still talking about post-laser vision correction, so of course, I have the IOL Master 700, no financial interest. I consider it because it takes into consideration the anterior and posterior together. It takes into consideration as well the predicted ones, taking the ratio, the real ratio, not the one, the average one calibrated with other machines. And it measures the central 4 millimeter zone, not circle zone. So this is what the patient needs. Everyone sees through this zone. So I'm very happy with that. Yeah.
So a 4 millimeter on an IOL master would be an ideal scenario. We're not looking at 5 or a 3.5 or 4. Wonderful answer. I mean, to the point, 4 millimeters. And what if you have a lens star, which is the machine that your K reading, because as you said, almost one diopter change on a K reading can change your lens power one diopter. And that makes a hell of a difference. So if you have any other machine, a lot of people who would be listening may have immersion biometry, may not have this. So which is the K reading that you would have the gold standard to listen to?
Yeah, thank you very much. Now, if we have optical devices in general, whether they are IOL Master or Lens Star or whatever, they have the same concept. So we can consider the 4 millimeter central. Now, if we don't have access to this one, this is in any country can happen. All right. So in this case, we should have a topographer. A tomographer, because we need both surfaces. We cannot depend on the SIM-K. We cannot depend on the autoref. The autoref, indeed, it is the worst machine in the world. We should not depend even in single refraction. So we have to depend on tomographer. And as I said, if the cornea is regular, we have to depend on the total corneal refractive power because it depends on both surfaces. It takes the thickness of the cornea into consideration. It takes a zone rather than a circle. And it depends on the real refractive index of the cornea, not the keratometric index. So the 1.376, this is the one, the real stromal refractive index. If I have the Cyrus or MS39, then I can go to the refractive analysis, and there is the mean pupil power at 4 millimeter. It will give me similar to the Pentacam in the total. So I take this one and then I put it into the Barrett True K online, okay? Because there is no excuse. everybody now has an access online to those formulas. They are free. So we put those and then we proceed. Now, at the same time, those formulas, they have as well the possibility for everybody to put even the measured SIM-K. No problem. They can predict accordingly. So those formulas online make our life very easy. So whatever you have, you can get good results.
Thank you so much, sir. I mean, thank you very much. The Kane formula, which you emphasized on, most people have now shifted on to the Barrett online and or the other Barrett formula. But the Kane is an interesting situation which you gave, and I can see your emphasis on that in the first two cases. Thank you so much. I'll come back to you again, sir, on the interest of time. Over to you, sir.
Yeah.
On.
Thank you. Thank you, Dr. Mehta, sir. So I would like to now go to Dr. Vavikar, sir, for your comments, and also if you have any questions for Professor Sindha.
Sir, a very excellent lecture, especially the way you drew decision tree regarding the aberrations. It makes life very, very simple for a lot of people. And like somebody who can draw such a decision tree obviously is very well versed with the subject. So that speaks very high of you. Thank you very much. Now, my question is that you alluded to measured PCA and you have ILMaster 700. So is there any particular reason why you did not mention Barrett TrueK TK?
In the Barrett TrueK
TK.
Sorry, this is the formula itself. It is online. So I didn't get your question. So again, please.
So in ILMaster 700, there is an upgrade which has come by which you can use Barrett TrueK TK.
Yes.
So that we don't have to use this measured, and it directly measures and calculates. So any
exactly.
Or both are same, or you feel that the one which is online is better?
Very good question. Now I got it. In the ILMaster, it is already built there, so you can get the numbers directly. But in the online, I always, if I have a patient with keratoconus or irregular cornea or post-laser vision correction, I do double check. I go to the online formula, I follow the MPCA in order to be sure. Very rarely there is maybe a fraction of diopter difference. So if I find a fraction, maybe 0.5 or something, I depend on the online one, MPCA. And however, it is maybe 0.25 or 0.5 difference.
Yeah. And so the second question is that for post-RK, because there is a interformula variability is there, and it is very high in RK patients. So which are the two formula you will ask people to use, which are available online also, so everybody has access to it? Which two formulae?
Barrett TrueK as well. This is one of them. And I cannot recall the other one, actually. I can see it now, if you wish, because I have a very long presentation regarding the same. So if you allow me just to see.
Yes.
What I use is the Barrett TrueK, because it is good for any type of post laser vision correction or any correction on the cornea itself. Just opening the presentation.
Yeah. I think till that time, probably we can take a comment.
I can make a comment?
Yes, please.
We are talking about EKR. Now, EKR is reliable only if there is one single spike.
Yeah.
If it is flat, EKR is not reliable. And we have to choose the EKR 4.5 value. Because there is EKR 2.5, 3.5, 4.5, 5.5. It is always EKR 4.5 we have to choose. And especially in RK patients, sometimes the K is so low that your machine is not getting it, and sometimes
Yes.
the K is so low that the formula is not accepting it.
Right.
So for both there is a method. If you have a low K which is not able to, which a machine is not able to measure, then you put -1 in front of the eyepiece of manual keratometer, and whatever K reading you get after looking through that, you multiply it by 0.84, and that is the final K you take for calculation. Similarly, if you have, like suppose any Barrett K is accepting nothing below 30 diopters, but your K reading is 27, then that 3 you multiply it by 0.84, and whatever answer comes, you subtract from the IOL power you got, and you will be very close to emetropia.
Right.
Yeah, interesting. Thank you very much. It's still uploading.
No problem.
No idea. If any
Quickly,
question,
Vardhaman, if I
Yes.
ask Professor Sinja, so
Yeah.
is it possible for you to share your presentation? You said it's a big presentation, but it'll make a lot of sense to us over a period of time if you can share it.
Yeah, sure. I usually teach this subject on Sinjab Academy in the Masterclass of Refractive Surgery. So yeah, it is a session of 2 hours actually about biometry, only biometry.
Exactly.
So here we come. Yeah, Pareto K formula. And no, I'm not aware of any other one.
So normally what we do is that we go for ASCRS average.
Yeah, of course, there is ESCRS. But in the ESCRS, you have Barrett and the K6, EVO, Hill RBF, Hofer UST, and Peel DGS. So which one of them will be useful for the RK?
So I will be going for average, but slightly biased towards Barrett K. For example, suppose the average is 35, meaning 35, say 19 diopter IOL, and Barrett K is saying 18, then I will go for 18.5. So average between the two.
So averaging, you mean? By the way, the askers, everybody, there is a calculator, has been since 10 years, I think, or even more. Shammas formula is very accurate, is the most one accurate. Sometimes I go to that formula sometimes to make a comparison. Yes.
So we would like to now go to Dr. Ladi sir for his comments, and if you have any questions. Yeah.
Hi, Sinjab sir. Thanks a lot for making non-toxic topic into a totally nice one and making it so non-toxic that everybody understands the concept about the aberrations and other things. One thing which is there that you say that the measured posterior corneal surface. Now, most of the studies and shows that anterior corneal surface measured is fairly accurate, while posterior one it's not shown anywhere that all the time it is reliable. So instead of making measured posterior corneal surface, why not to go for a presumed posterior surface, which is having a, you can say, maybe a regression formula done over a number of cases, which can give us a reading. That's the first point. Now, if you take a myopia up to 2-3 diopters, the flattening is there. We can measure the K readings at 3 millimeter area. But if I want to cross 5 millimeter of myopia for a correction of myopia by refractive surgery, the flattening can go up to 4 millimeter to 6 millimeter, which may not be valid onto any optical biometer. So we'll have to depend upon the topography, especially anterior topography, not SIMK, but center 3 millimeter K1 and K2, taking average of that. That we have found that Sharma's equation, which modifies your by taking average of 1.14, multiplied by minus 6.8 gives more accurate readings than the direct to K, which comes myopic by 0.5 or 0.75. That's one thing. Another thing is that astigmatism, instead of taking directly, why not to take from an anterior topographer and draw a line at the most steepest point and take that as the axis and implant the lens. Thank you, sir. Your comments, please.
Yeah, thank you very much. Now, for the first point, which is we cannot measure very well the posterior surface. Correct? Did I understand that?
Correct.
Yeah. So you want to measure only the anterior, and accordingly we predict the posterior one?
Absolutely.
All right. But I don't think that from the anterior we can predict the posterior, because the posterior sometimes has its own irregularities, which usually compensates for the anterior one. So how we can predict the posterior from the anterior?
No, I'm saying that in this there are two. One is measured posterior and one is presumed posterior, right? In your software.
In the formula, I mean.
Predicted.
In the formula.
One is measured, another is presumed. The presumed means that they have measured multiple n number of cases and they have come to a regression value. Why not to take that than a measured value, which is still not very sure?
Yeah, very good. Now I got it. Because there is a study, I didn't show it here. The study compared between the predicted PCA and the measured PCA. And it found, according to the study, it found that the measured is more accurate, just a little bit difference. So according to the study itself. So it is statistics only.
Okay.
Based on the study. Yeah.
Can I add?
Yes, please.
In normal virgin corneas, there is no difference between this, the measured and predicted. But in post-refractive cases, Barrett Triquet or measured PCA improves the result by 12%. There is a study like that. And 12% is the number.
Interesting. Yeah. So the second part, your voice was like interrupted because of the internet. So we didn't get the point. If you can repeat it, please.
The second part was that we depend more on see, if the myopia is low, say up to 1 diopter to 3 diopter, flattening may be up to 2 to 3 millimeter. If can you hear me?
Now
Yes.
it is. Yeah.
Can you hear me?
Yes.
In a higher myopia, your flattening is more. It may. Hello? Dr. Chandrasekhar, can you mute yourself?
Yeah.
No, Dr. Chandrasekhar, can you mute your mic?
Oh, I'm sorry.
Can you hear me now?
Yes, sir.
Okay. Now, when you cross a myopia 4 to 5 diopters, your flattening is in such a way that your K is taken beyond 4 millimeter, maybe 4 or 5 millimeter, maybe 6 millimeter, if it is 8 diopter myopia, where optical biometry, like either Lenstar or ILMaster 700, may not be able to take that measurement. So why not to take that measurement from a tomography at 3 millimeter, not SIM-K, but 3 millimeter area of your tomography. Are you getting, sir?
Yes, okay. So this is what I mentioned. If you cannot have an access to the optical devices, or we can add your point, of course, if the optical device cannot measure because if the cornea is too flat, for example.
Absolutely.
The only way is to go to the tomographer, not the SIM-K, of course, tomographer. And if the cornea is regular, we go to the total corneal refractive power. Usually I do the 4 millimeter, not 3, the 4. All right. And if it is irregular, then I go to the EKR. Yeah, your point is valid. I agree with you. Yeah. So the third point.
Thank you. Third point is astigmatism. Now,
Astigmatism.
instead of measuring that,
Yeah.
any anterior topographer, not necessarily tomography or a Shampling imaging, even a simple topographer will give a fairly good reading of anterior topography. So when you see the most steepest, darkest red point of the steep part, just draw a line there and take that as an axis and implant the lens in that axis. This is what I was suggesting.
Well, in this case, we are excluding the posterior surface. And we know that the posterior surface, if we exclude it, then there will be an effect on the final. We know that either overcorrection or undercorrection, especially if we are implanting the toric lenses, according to the studies. So myself, no, I don't depend only on the anterior surface. I depend on both, because if it is against the rule, with the rule, so, it depends. The posterior, anterior, they compensate sometimes and they add sometimes. So we have to consider that. Otherwise, we will end up with either undercorrection or overcorrection.
Right, sir. Thank you, sir.
Thank you,
Pleasure.
Dr. Yes. Dr. Gaurav, if you're online, if you would like to probably give your comment or, yeah.
So I really enjoyed the whole discussion. I've been glued to the presentation and the discussions. Amazing. I just wanted to ask, everything's already been asked actually, but we've been using the Anterion. And I found that, the optical biometers which can't measure Ks, which are either too flat or too steep, the Pentacam and the, OCD based devices can do it. So we've been using Pentacam for good 15, 20 years, whenever we got it last. And we really trust the EKR and everything, as everybody discussed. I wanted to ask Professor Sinjab whether he has any experience with ray tracing. We've tried to use ray tracing in addition to all the others like the Barrett's TrueK, and we also use the ASCRS calculator, and now the ESCRS also has certain things available on it. And we found that on the ASCRS, the Pentacam, usually the outlier is the one which we get from the Pentacam for some reason. We also use the OptiView OCT, posterior corneal measurements, and we've tried almost all those things. I found that somehow the Pentacam measurements, based through the ASCRS calculator tends to, be the one which is most off. So we don't trust it as much, except that otherwise we would trust it. So have you got any experience with the ray tracing ones as compared to all these other, methods of calculation based on the other formulas in post-refractive surgery?
Thank you very much. Very excellent question. I have no experience, of course, but I heard from experts who tried it that it is the future. Actually, the ray tracing is the future. Yeah.
So we've actually been studying. We've done about 70 to 80 eyes of post-RK and post-refractive surgery, and also because it does give a very good toric calculation in addition to the spherical calculation. But our experience has been that it works amazingly well in certain eyes, and it does not work well, and it's totally off in a few other eyes from all the other conventional methods of post-refractive surgery calculation. We still haven't found the confounding factor that where it works and where it does not work. So I thought, that this point, if anybody else or, Professor Sinjab had any thoughts, but since you haven't used it, but if anybody else has used ray tracing and would like to comment, I would be so happy.
Yes, Dr. Bhavik, yes, sir. Yeah.
Gaurav, which one you are using, Olsen or Oculix?
Oculix.
So,
Olsen I didn't like much at all. Oculix is what we've been using, which is inbuilt into the Anterion. And so it makes it very straightforward to use it because you don't have to kind of feed the data and populate it. It takes it automatically. But that's my experience. Yeah.
So we are also using Oculix. My database is obviously not as much as yours, but what we have found is that Oculix goes very close to, prediction goes very close to Barrett TrueK TK. So,
yeah, sorry. Yeah,
no,
go on, sir. Go on.
Please.
Go on, sir. Thank you. The AI, here is the role of the AI in order to predict which factors affected the results graph. You said that the ray tracing did not work in some cases, and till now you couldn't figure out which parameters affected this. Here is the role of the AI. Indeed, I'm working now on a formula based on the AI in such cases to predict factors and to be independent uh, of some factors that may have a very high influence on the results. So the AI is excluding factor by factor, and we will depend, and as well we are building sometimes some derivatives from a combination of parameters in order to like go around. So if anyone would like to participate in this formula, you are most welcome. We can contact later. I'm working with this with my son because he is data scientist and artificial intelligence scientist based in the US. This is his main subspecialty, actually. So everybody is invited to participate. We can find a way to build something together. Thank you very much.
Thank you, Professor. Thank you.
That's nice.
Karishma,
Thanks
do you
for
have any questions, or Dr. Balakrishnan, sir?
I think most of the questions have already been covered. So thank you very much, Dr. Sinjab. It was an extensive and a very well covered talk. And thank you all our panelists for adding to the discussion and making it such an enriching experience.
Thank
Great.
you.
Over to you, Vardhaman.
Thank you. Dr. Balakrishnan, sir, if you're online, if there is anything you would like to add or ask. Dr. Atulji, if there is anything that you would like to add or ask. Okay, so I think we have had, I think, a great discussion overall. I think we learned a lot about the post-ICL cataracts and its nuances. And of course, from Professor Sinzab, we have learned so much about the post-corneal refractive surgery biometry. I think this is a very, very difficult topic to master. And as Professor has correctly said, it is a 2-hour topic for us to understand. But in 20 minutes, I think Professor has given us a lot of amazing details. It is a complex topic on its own, but definitely we will dwell more in details in the future. And Professor, we would like to, of course, have you again in the future for probably more detailed discussion about the same topic as well. So before we go further, one small thing we are going to do, and now that we have Professor Sinzab as well as Dr. Gaurav here with us, we all know that the MOSCON 2024 is coming up now in Solapur very soon. We have released the program almost, I think, 2-3 weeks ago, about 3 weeks ago. But we last year we started to have a very interesting thing, which was a navigation-enabled, touch-sensitive program book, so that we don't have to actually print any book as such, and you can go from any page to any page with a click of a button. So that will be released tomorrow. But because I would like to just request Dr. Aditi, who is the Secretary of Scientific Committee, to just share the program book. We have our President, Dr. Agarwal, sir, here with us. Sir, your comments and if any questions for Dr. Sinjab, sir, and then we'll go for that. Yes.
No, very extensive discussion on the very important topic. I think we have to read further. So many things we have to still digest. Is not digestible.
It's a complex topic.
Because yeah, very complex topic, but he has made it very easy.
Yes.
And it will definitely induce interest in such type of because so many patients are coming nowadays of post-refractive surgery for cataract surgery. So we need in-depth knowledge of all those things, definitely. And it's really helpful for our all colleagues. And thank you, Vardhaman, for inviting such a very stalwart international faculty, and our own faculties also. They have also added so much knowledge to this webinar. Thank you, everybody. And
so, sir, with you being here as our president, and also Dr. Balakrishnan, sir, and Professor Sinzab, Dr. Gaurav, all our panelists, Dr. Himanshu, sir, Dr. Ladi, sir, and Dr. Vavikar, sir, we wanted to tomorrow, as we know that we are going to showcase the navigation enabled program book. But I just thought now that we have the program book with us, probably we can release it here, and then we can share with everybody tomorrow. So can we request Dr. Aditi to share her screen?
Yeah.
Yes. Okay. Please, Aditi, please share your screen. Now, this is 120 sessions have been curated. We have 200-page program book, almost 400 and plus speakers. And Aditi, can you just make it full screen? You can make it full screen. Your this one, the thing that you're sharing. No, it is okay. No problem. So, and now these are beautiful paintings by our MOS members. You can scroll through, Aditi. Yes, yes. So these are all the details of all the sessions. You can keep scrolling. Yeah, yeah, yeah. Our president, yes. All the addresses. I think the LOC team has done a stupendous job, amazing job in putting this bowl show together. We are very thankful also to all the program committee, all the past presidents, all these beautiful paintings by our members and our international faculty, our national faculty who are joining us from all over India. We will be missing Dr. Gaurav this time and also Professor Sinzab. We had invited both of them, but Professor Sinzab is going to American Academy and Dr. Gaurav is also very busy with the midterm meetings. These are all our MOS faculty. And these are again some beautiful paintings by our members. These are some of the special highlights that we have this time, many of them for the first time in MOSCON. And we all know that this is a one specialty, one hall kind of concept. This is a 3D show, which will be one of the highlights, and also the Botox on the silicon model. And Uvia, Kaun Banega Uvia, Pati by Partho, etc. So this is the skill transfer courses. These are probably the biggest that we have had so far. And the beauty of this navigation page is the one that is going to come now, which is the overview page. So actually, this document is touch enabled, as you can see here. So this is written that this document is. So if you go and click on any button on any of the boxes, you directly go to that session. And when you go to the session, Aditi, if you can go further,
Yes.
you can go in one of the sessions, please.
Yes, I'm doing.
And if you go to any of the sessions, you will see 3 clicks here. So you'll see day 1, day 2, and day 3. You can go to the grid directly. And that makes it very, very easy in this exhaustive program for people to navigate. So yes, just wanted to showcase this is what we are going to show, release tomorrow. Thank you to our president, Dr. Agarwal sir, our BO president, Dr. Balkrishnan sir, and everybody, all the MOS team for all the help. So yeah, so a few
Actually, Vardhaman has taken extensive efforts for coming out with this innovative idea and all those things. We are seeing this is the first time. So he has done a good job. Congratulations to Dr. Vardhaman, Aditi, and
Aditi has
scientific
put in a lot of
committee.
efforts. Very sincerely,
Yes,
she has
yeah.
worked a lot on this, and all the scientific committee with the help of course, Dr. Agarwal sir, Dr. Atulji, Dr. Mandar sir, and a whole team. So we all look forward to see all of you in Moscow.
So we invite all of you to Moscow 24 at Solapur, and looking forward to a great conference.
We are going to really miss out.
Anything you want to say, sir? Sinjab, sir, if you want to say something about this.
Yeah, many congratulations. This is really excellent work. I'm very sorry that I'm going to miss this huge conference. And for sure, next year, count me on.
Thank you.
Definitely. Yeah.
Thank
Dr.
you.
Gaurav.
Right. I was also thinking that, what an amazing program. I mean, this is looking as big as the AS conference. And Santosh sir and the whole team of MOS, I must congratulate you. I'm really going to miss it. It's just that my AS midterm commitments for the live surgery are just 4 or 5 days after this meeting. Otherwise, I would have surely been there. So it's my loss. And keep up the great work, Vardhaman, and all the best for your future, and all the other team also to do so well in future as well.
Thank you. Thank you. Quick comments from our also panelist, Dr. Himanshu sir.
Everybody has said so well, and a lot of hard work can be seen behind. There's no question about it. Some innovation, and as always, so much more to expect. This venue becomes incidental, but the whole planning and execution, the way you've done it, and the enthusiasm is absolutely heartwarming. And all the very best for this conference. Looking forward to attending and having a great time there. Thank you so much.
Yes, sir. We are looking forward to have you with us. Yes, Dr. Ladi sir, please.
Ladi sir.
Yeah, I would like to thank Dr. Santosh Agarwal, our president, and Dr. Vardhaman for creating such a innovative program, making it unique for the first time for MOS. I'm going to be seeing this in future, making it more and more scaling to new heights. And thanks to Dr. Vardhaman again for taking so many efforts to make it unique. Thanks a lot. Thank you.
Thank you, sir. We look forward to see you also in Solapur. And we look forward to see also, of course, Karishma and all our friends from BOA. And I would like to now request Dr. Karishma to give the final vote of thanks.
At the outset, I would like to take this opportunity to thank Vardhaman and the entire team of MOS for involving us together in this coalition of an MOS BOA program. I would also like to congratulate all the MOS team on the great work they are doing. And I would like to take this opportunity to welcome you all to the annual conference of the Bombay Ophthalmic Association, which is Focus 2.0. This will be the second conference in the same year for the first time. And it's going to be on November 29th, 30th, and December 1st. So, welcoming all of you. The Bombay Ophthalmic Association meeting. And Vardhaman has already set the bar very high. So, we have some great expectations to be met. Without wasting any further time, thank you all of you for your participation. Thank you, Dr. Sanjab. Thank you, Dr. Gaurav, for your invaluable inputs. And with that, we'd like to conclude for tonight.
Thank you. Thank you. Good night.
Everybody, good night.
Thanks.
Thank you, everyone. Thank you.
Thank you, everybody. Good night.
Thank you. Thank you.
Good night, Dr. Atulji.